Hi, friends. I hope some of you have had the chance to see and listen to my past five iterations and reminiscences of certain paradigm shifts which I have been privy and witness to since I began my career as an intensivist 20 years ago. I'm sure some of you would have identified some more paradigms which I have missed, but I think that's the experience we all get by working for long years in the intensive care unit. We have spoken about fluids, we have looked at ARDS, we have looked at SEPS, we have looked at AKI, we have looked at nutrition, so many aspects of intensive care. But the integral part of intensive care, which probably has also seen some paradigm shifts, is hemodynamic monitoring. And this is one area where our country has actually contributed to certain new and innovative methods of measuring or identifying the dynamic indices of wall fluid responsiveness. Way back in 2000, 2002, when I was trying to find my feet in this field of intensive care, Emmanuel Rivers actually came out with his seminal paper which spoke about certain methodological aspects and putting some kind of process and some kind of algorithm into resuscitation of patients in the emergency rooms of developing countries. And it included central venous pressure, but it also included some interesting parameters like SCVO2 and hematocrit. And they tried to put that into an algorithm and said that if you have a number of SCVO2 in this range, these are the interventions you should be doing. This is the hematocrit you should be trying to maintain. And it also put a method into the whole process of fluid resuscitation in emergency rooms. This impactful publication from Rivers actually was so effective and so influential that these recommendations actually made their way into the first of few guidelines of the Surviving Sepsis campaign. And we all practiced it for quite a long time, maybe as long as 2007, 2008, we were practicing some of the recommendations of the Rivers paper. Since then, except for the mean arterial pressure and to some extent the SCVO2, most of these recommendations have waned off as prime entities for hemodynamic optimization and hemodynamic correction among sick patients who come into the emergency room and from there into the intensive care unit. The CVP has been probably the most enigmatic of all these paradigms, of all these parameters. There were believers long before, and probably there are still believers in CVP as a hemodynamic tool because it's the most easily available, most commonly used, and most readily replicable, and probably the least invasive of all the tools we have at our disposal. So, we began to understand that assessing somebody's volume status based on a low CVP may be erroneous. And we also understood that those patients who are fluid responsive may actually have a normal CVP, and deserving patients may actually be omitted from getting fluids based on the CVP. From there, the CVP has evolved and emerged in a way that now it is considered that probably a high CVP is suggestive of a volume overload and it is time to de-resuscitate our patients. It may be true. And several surrogates of this, like the IVC diameter, the hepatic vein Doppler flow, the portal vein Doppler signals, the renal pulsatility, all these signs of volume excess have become normal parameters which we now assess as volume indicators of volume excess. So the CVP probably was the first such paradigm which emerged and gave us some understanding of how we should be measuring the response or the requirement of fluid. But as it waned off, it gave us some interesting answers and alternatives. The SCVO2, in my perspective, is a fantastic physiological concept which probably has not stood the scrutiny of meticulous scientific research. We all know that uncoupling of the electron transport chain at the peripheral level can result in poor offloading of the oxygen on the circulating blood, and that translates into very high SCVO2 values. So, while a low SCVO2 may not always be an indicator of fluid requirement or hemodynamic suboptimal homeostasis, a very high SCVO2 should probably ring alarm bells amongst the intensivists. Now, especially since two important molecules, the methylene blue and hydroxycobalamin, are coming back as interventions for hemodynamic optimization, the assessment of SCVO2 and a high SCVO2 as a marker of very severe disruption of the tissue oxygen delivery may be in the offing, and that itself will be a paradigm shift. Way back in the mid 90s and probably in the early part of the 2000 2001, dopamine was still being used in some ICUs despite the ANZIC's paper, which recommended that it should not be used as a inotrope in the intensive care unit. In 2002 and 2004, when I was training in critical care, the unit where I trained actually did not use dopamine, one of the first units not to use dopamine for hemodynamic optimization. And several, explanations were put forward, and we found that it is arrhythmogenic, it is immunomodulatory, it does not improve kidney function, and it probably increases the myocardial oxygen demand. So, dopamine waned off from its prime position as an inotrope in intensive care units. And then slowly people began to accept that norepinephrine is the drug of choice for vasodilatory shock initially, and subsequently for nearly every kind of shock except for probably obstructive shock. But vasopressin, norepinephrine alone was not giving the results, and somewhere along the line you got the VAST study which showed that vasopressin could be an additive working through a different mechanism which could help patients reach their hemodynamic targets earlier with combined with vasopressin. Again, the use of vasopressin had its proponents and its opponents. There were people who believed that it triggers mesenteric ischemia, it can trigger myocardial ischemia, and it can cause several other complications. But subsequent studies, although did not show as much mortality benefit as the earlier interventions, vasopressin was not shown to be a harmful agent, and it came to be an integral part of the armamentarium of drugs which we use to optimize hemodynamics among patients with sepsis or most kinds of shock. For a long time, maybe from 2007 or 8 till 2018, these two were the only drugs which were available for hemodynamic support in terms of vasopressors, until you had terlipressin being tried and with mixed results. But the most path-breaking paradigm that shifted is the use of angiotensin II. And angiotensin again has a different mechanism of action, and you can easily identify those patients who probably will benefit from angiotensin by looking at the renin activity. So this paradigm is probably now you have a sympathetic system targeted norepinephrine, you have the aquaporin targeted vasopressin, and then you have the renin angiotensin targeted angiotensin II. So this paradigm of hitting the hemodynamic axis from multiple angles seems to be a very interesting and probably effective paradigm shift that I have witnessed in the last 20 years. We still don't have angiotensin in India, but it's only probably a matter of time before it reaches our shores. Somewhere along the line, when the CVP started waning off and other parameters were not actually, and the pulmonary artery catheter also lost its place on the shelves of intensive care, two important dynamic indices made their appearance in intensive care units. And again, the unit where I trained in Bangalore was one of the first to use stroke volume variation and pulse pressure variation. These were very elegant and scientifically robust methods of assessing volume responsiveness using heart-lung interactions. But we all know that this probably were applicable only to a small percentage or maybe a one third of your patients who come into the intensive care unit because of the issues of not being effective when there is a spontaneous breathing, not being effective when there is a rhythm disturbance, and not being validated for tidal volumes less than 10 mils per kilogram of ideal body weight. And as I spoke about ARDS, the 6 to 8 mils per kilogram ideal body weight tidal volume began to be applied not only for ARDS patients but for all ventilated patients in the intensive care unit, including the perioperative and immediate post-operative patients. So, does the flow track, the so-called flow track, which looks at stroke volume variation, work when you have 6 ml or 8 ml tidal volume? And now are the days where we are giving ultra low tidal volumes to some of our patients. So, will it really work? That was always the concern. So, it was not applicable to the whole spectrum of hemodynamically unstable patients in the intensive care unit. And here we must appreciate that an answer was found by our Indian researchers who said that you can use a tidal volume challenge within the range described or prescribed by the ArtsNet group, but yet demonstrate responsiveness or the fluid responsiveness by looking at the tidal volume challenge test. So this has been a very exciting and rather very important paradigm for me, that you looked at stroke volume variation, you looked at heart-lung interactions, but you actually extrapolated the tidal volumes and manipulated the ventilator and brought heart-lung interactions into hemodynamic optimization to the bedside, which can be applied across the board, whether you are in a tier 3 or a tier 2 or a tier 1 city, in a teaching hospital or in a private healthcare facility. So it is not an exclusive and is inexpensive because the patient is on the machine anyway. So this paradigm of trying to bring the hemodynamic monitoring to the grassroots is probably has been a good paradigm shift for us. Another interesting paradigm that emerged and became well accepted, although its interpretation and its practice is up for debate, is the passive leg raising test. We were always concerned by giving fluids and fluid challenges that you could be actually tipping patients over into heart failure, especially in the context of low hemoglobin, which most of our patients come into the hospital with. So, the passive leg raising test, if performed as it is described and has been recommended, of course, combined with some kind of stroke volume monitoring, is probably an important paradigm that emerged in the last 10 years, which also is a less expensive and easily applicable and easily learned technique where you can identify those patients who are responsive or who are in need for fluids. The emergence of the passive leg raising test, as in my view, has been a good paradigm shift, as good as the tidal volume challenge. Now, the whole focus of hemodynamic monitoring and assessment has been to identify those patients who are in need of fluid. But the paradigm that has shifted and that has gone more importance in intensive care, and intensivists are learning the skills to test for, is identifying positive fluid balance. Yes, a meticulous chart review will always tell you if the patient is in a positive fluid balance. Whether this positive fluid balance is actually impacting the patient's hemodynamics can be done by now different methods of point of care ultrasound. This itself, the emergence of point of care ultrasound itself, is a major paradigm shift, and we will leave it for another day to discuss how POCUS has influenced intensive care. But as far as hemodynamics are concerned, while we were looking at the left ventricular ejection fraction, left ventricular end diastolic volume, and the velocity time integral across the aortic valve in the initial stages of hemodynamic monitoring, subsequently, we have learned to look at the venous system as well. We routinely started looking at the IVC diameter, its variability, the superior vena cava compressibility and distensibility. And we tried to extrapolate that and say that if this is the number, this is the percentage of variation, this is my possibility that my patient will be fluid responsive. From a uni-focused approach of identifying a full IVC versus a collapsing IVC, we have now gone to quantify the extent of fluid overload by the VEXAS protocol. We are looking at the hepatic vein, we are looking at the portal vein, and we are looking at the renal veins, and then with definitive Doppler patterns, and able to tell that these patients, the degree of fluid overload, and quantify them and grade them in a replicable manner, so that if you have initiated a process or a treatment for the decongestion of the patients, you can actually do it serially, and you can and quantify how effective your offloading of fluid of this patient has been. So just from looking at ejection fraction and the filling pattern of the ventricle to the point of a quantifying assessment with ultrasound has been a good paradigm shift. While we are on that topic, the focus among intensivists has also changed from looking only at the left ventricle from a hemodynamic point perspective, from change to learning the techniques and learning the importance of the right ventricle as well as an important player in the whole cycle or in the whole game of hemodynamic optimization. The tricuspid annular plane systolic excursion, for example, has crossed the boundaries of only pulmonary thromboembolism and has crept into assessment of RV dysfunction among patients who have hypoxemic respiratory failure, who have ARDS, who are on higher PEEPs, and who are given a lot of fluids for resuscitation. So the emergence of sonographic assessment, including the lung ultrasound, to tell you which patient has actually accumulated more fluid and which patient probably can take in more fluid, has been probably one of the major paradigm shifts in my perspective. And of course, the importance which we are now giving to the right ventricle when you are assessing somebody's hemodynamics has been probably the most physiologically relevant and often ignored paradigm which has shifted in the last 20 years. A simple bedside test which can tell us that your perfusion is getting better or your perfusion is not getting better has emerged after the Andromeda shock trial validated the use of the capillary refill time. Of course, the method that was described in the trial is a very specific method of doing it, but if you can do it at the bedside, the capillary refill time has been shown or has been proven to be comparable to lactate and its clearance. A reduction in the capillary refill time has been shown to be equivalent to a lactate clearance when you are optimizing patients with hemodynamics with fluids and vasopressor therapy. So in the end, I think while we looked at CVP, we looked at stroke volume variation, the waning off of SCVO2 or its interpretation in a different way. We also have looked at the arteriovenous carbon dioxide gradient. We now have understood that a wider gradient is probably representative of a cardiac cause of the hemodynamic instability than a vasodilatory cause of the hemodynamic instability. So this has been also an important paradigm shift in the management or in the recognition of hemodynamic instability. There has always been a debate that a patient who is getting norepinephrine should always get a central line. And for a good part of the last 20 years, that was the norm. If you started vasopressors on somebody, you would make every diligent effort to put in a central line. But of late, this paradigm has shifted, and smaller doses of norepinephrine are now considered safe to be given through a peripheral access for a reasonable length of time before a trained hand can put in a central venous access. So the whole purpose of this paradigm shift, in my understanding, is that it will not delay the administration of a life-saving medication which will defend somebody's mean arterial pressure. So friends, I think as far as hemodynamics are concerned, the changing role of CVP and the changing role of SCVO2 versus the emergence of the tidal volume challenge and the capillary refill time, with understanding of different techniques of identifying fluid overload and acknowledging the role of the right heart in the whole gamut of hemodynamic optimization, the more widespread application of the passive leg raising test, and the application of a simple bedside test called the capillary refill time have been some of the more important paradigms which have shifted or emerged in the field of hemodynamic monitoring in the last 20 years as an intensivist. I'm sure I would have missed some paradigms. Some of you would probably understand and would realize that I have missed a few of these. I've had some messages from some of my friends who have listened to my discussion and said I have missed certain things. Of course, I acknowledge, but it's individual perspective that makes a difference, and I'm happy if some of you can actually tell me personally what paradigms I have missed in hemodynamics. Till then, friends, have a good time and bye bye. Hello, friends, and I'm back again with some more reminiscences and contemplations about some paradigm shifts in the field of intensive care. If you want to talk about a paradigm which has spread across the various aspects of critical care and has made a difference to the way we monitor and deliver therapy to our patients in the intensive care, it's probably the point of care ultrasound. It's probably the true paradigm shift which we have witnessed in the last 20 years. When I began my career 20 years ago as a trainee in intensive care, the ultrasound was limited to cardiac echo, focusing on the left ventricular function. There were a few intensive care units even at that time which were looking at ultrasound as a means of guiding your vascular access, and that was not a continuous or a real-time ultrasound. You were marking the anatomy and then doing the vascular access. From then on, the vascular access being obtained through point of care ultrasound has evolved, and to the point that today positioning of ECMO cannulae and other highly invasive vascular devices is guided by point of care ultrasound. This has really made a difference to the safety of these procedures and probably has saved reasonable number of lives, although I can't give you a number needed to treat for this particular intervention. It's become standard recommendation for all intensive care society guidelines for vascular access. Similarly, the realm of ultrasound of the heart or cardiac ultrasound has also evolved over a period of time in the last 20 years. When we first started using ultrasound, we focused on left ventricular ejection fraction. Some of us used to look at the velocity time integral across the LVOT, and then we were looking at the pericardium and the regional wall motion abnormalities. Pretty much what the cardiologists would also do. But as the understanding about the value, the role, and the importance of the right ventricle in intensive care grew, more and more emphasis was laid on intensivists learning the nuances of assessing the right ventricle, the right ventricular strain, for example. To some extent, credit should go to the work done in the field of pulmonary embolism, which actually showed that the tricuspid annular plane systolic excursion is a good sign that your RV is not working well. The same logic was then applied to other areas where the right ventricle is under strain, like ARDS and hypoxemic respiratory failure, where a worsening tricuspid annular plane systolic excursion is an indication that your right heart is working against increased upstream pressures. As we progressed and as we learned more and more about the way the ultrasound can be employed, it became a standard part of assessment of all patients with shock, and we developed the tank, pipes, and pump concept. So we were able to look at the blood vessels, we were able to look at the heart, we were look at the great blood vessels of the thorax, and then understand what could be the etiology be for a patient presenting to emergency room with shock. So the role of ultrasound as the primary screening tool for patients presenting with undifferentiated shock has also probably streamlined the way we utilize other investigative modalities and prioritize what we do for our patients presenting in shock. And that's probably been a very significant and useful paradigm shift as far as ultrasound of the heart is concerned. While we still look at tamponade, we still look at pericardial diseases, we still look at ventricular free wall rupture, we are also looking at the right heart, its function, and its upstream performance using ultrasound. So that's probably been a good paradigm shift as far as cardiac ultrasound is concerned. Another area which probably has progressed by leaps and bounds, and you can say something which could not be imagined 20 years ago, is lung ultrasound. Ever since Liechtenstein proposed the Blue Protocol, a lot of this assessment of lungs with hypoxic patients has been based on lung ultrasound. And it's now become a standard practice to have an ultrasound done on every patient in the intensive care who has suddenly dropped his saturations or dropped his PaO2. And it's a replicable model, and it's easily storable, and it is documentable. So simple documentation of a few parameters like the B lines would exclude a life-threatening problem like a pneumothorax, instead of wasting time waiting for a chest x-ray, doing expensive investigations like an HRCT, or doing potentially dangerous procedures like a chest drain in a hemodynamically unstable patient. From assessment of hypoxia, the lung ultrasound also progressed to assessment of patients who are on treatment for hypoxemic respiratory failure, read ARDS. So when you put these patients on mechanical ventilator support and try to recruit the patients, was the recruitment successful or not? Is your PEEP effective or not? Has there been de-recruitment for the patient? And if you prone the patient, has the prone ventilation succeeded in recruiting more areas of the collapsed lung? This information was not readily available, although subsequent information through driving pressures and other parameters can be obtained as surrogates, but physical demonstration of resolution of a confluent B-line profile to a less confluent B profile is probably more elegant way of understanding that you have been able to open the lung in the true context of the word. So it has also become an integral part of delivering therapy for hypoxemic respiratory failure, not alone diagnosing patients with acute hypoxemic respiratory failure. ARDS, of course, has got a lot of other problems like pneumothoraces, barotrauma, pleural effusions. So all these confounding factors for a patient with ARDS can also be identified and documented and probably be quantified using a lung ultrasound. Once your patients have been on a machine, you're always trying to wean them off ventilatory support. And the area of weaning has always been an area of intense investigation amongst researchers in the field of intensive care. The rapid shallow breathing index, the biomarkers, the cardiac function, they all have become points of research. Now the role played by the diaphragm, its contractility, its stretch, and its shortening fraction as a contribution or a contributor to weaning success or weaning failure have also now been properly documented with the use of diaphragmatic ultrasound. So a combination of a diaphragmatic ultrasound and assessment of right heart function during a weaning trial can predict which patient of yours is actually going to sustain an extubation after satisfying a spontaneous breathing trial, to the point that there have been suggestions that we should have something called as a diaphragmatic rapid shallow breathing index to quantify those patients who successfully withstand the process of liberation from mechanical ventilation. For those unfortunate patients who don't actually sustain this test and get hooked onto the machine for a long time, we usually go through a tracheostomy. And tracheostomies now are increasingly being performed under ultrasonographic guidance. We used to do them under bronchoscopic guidance before, but the paradigm is now shifting towards ultrasonographic guidance for tracheostomy. Emergency airway access also has progressed to the point that we now confidently can secure an emergency airway with the help of a tracheal ultrasound. One difficult area where point of care ultrasound has probably taken a longer time than other areas is neurocritical care. Transcranial Doppler has always been available in the hospitals and has been used in certain specific situations like subarachnoid hemorrhage. But with the advent of portable machines, the more easily available portable probes and the more widespread availability of training programs, training the intensivists in the art of transcranial Doppler has brought this test into the intensive care unit to screen patients with multiple other disorders like traumatic brain injury, for example, like an in hospital cardiac arrest, for example, and acute ischemic strokes, for example. In all these areas, the transcranial Doppler has found some application as far as its role in understanding the cerebral hemodynamics is concerned. One interesting aspect which runs hand in hand with the transcranial Doppler is the optic nerve sheath diameter. It does have some caveats and it does have some concerns about using the optic nerve sheath diameter, but it is probably a good screening tool combined with transcranial Doppler to identify those patients who probably need more advanced hemodynamic monitoring, cerebral hemodynamic monitoring. So it is probably a good paradigm that ultrasound in the form of a TCD and an optic nerve sheath diameter has now come into the hands of the neurointensivists. When it comes to gastrointestinal intensive care, gastrointestinal aspects of intensive care, ultrasound did not find much role till recently when we started using it for placing nasojejunal tubes and nasogastric tubes. It's a very reliable tool to actually place a nasogastric tube under sonographic guidance. The other area where the use of ultrasound has become very clear and very useful is in assessment of gastric residual volumes. We usually tend to interrupt the nutritional therapy for our patients in the intensive care going by a gastric residual volume aspirate, but the ultrasound is a more reliable and more sensitive tool to tell you whether there is gastroparesis and there significant gastric residual volume. The assessment of the portal vein and its flow characteristics has also become an integral part of assessment of patients with fluid overload and with chronic liver disease in the intensive care unit. While assessment of the portal vein diameter and its correlation with chronic liver disease is the realm of the qualified radiologist, the assessment of the portal vein Doppler form or the Doppler trace is a part of the VEXAS protocol, which tells the intensivist that it's time to relook at offloading your patients who are overloaded with fluid. So it therefore becomes an integral part of your hemodynamic optimization. In the aspect of renal patients in the intensive care unit, point of care ultrasound has always been for a long time has been a part of assessment of patients with oliguria. Although obstructive uropathy in the intensive care unit is one of the rarer causes of oliguria, with hypovolemia and hypotension being the more common and the more likely causes of oliguria, exclusion of an obstructed outflow with the help of POCUS is a first step in the assessment of patients with oliguria in the intensive care unit for obvious reasons. So it was always been a part of the tools available to us, and the portable machines have made it and have integrated it into most algorithms. Now, the point of diagnosis of acute kidney injury has again been a point of debate. We always have gone with serum creatinine based scoring systems and predictive scores for identifying patients with acute kidney injury, but are we missing some of these patients who would probably have avoided going into acute kidney injury by using some other parameters? Biomarkers are an integral part of this exercise in identifying those patients who have functional derangement before structural derangement in the form of who have structural derangement before functional derangement in the form of raised creatinine comes into the fore. So renal resistivity index is one such sonographic parameter which is being investigated to understand whether we can actually identify these patients who probably can be prevented from developing acute kidney injury. As I said before, assessment of fluid overload is now an essential part of resuscitation or de-resuscitation, and the VEXAS protocol includes the renal Doppler to know how far your fluid overload has gone, and the presence of an abnormal renal venous Doppler signal is signifies grade 3 on the Vexus protocol for fluid overload. So it's always been there, it has always been a good tool, and it's now come into the fore and become an integral part of assessment of patients in the intensive care unit. The sonographic vascular access has always been, as I said, was an integral part, but the nerve blocks, which sometimes have to be administered in the intensive care unit for some procedures, can also now be done with the use of point of care ultrasound. Nutrition, as I mentioned about the gastric residual volumes and nasogastric tube placement, nutritional assessment of these of patients in the intensive care unit is a difficult and often nebulous area. So, assessment of muscle thickness of 2 or 3 different muscle zones and a graded measurement of this thickness over a period of time in the intensive care unit is one of the more elegant and one of the more effective ways of identifying loss of muscle mass, read as sarcopenia, in patients in the intensive care unit. So, if you look at the paradigm shifts which ultrasound has given, or which has generated, right from cardiac ultrasound to lung ultrasound to neuro ultrasound, nutrition, vascular assessment, fluid assessment, it has been a true paradigm shift. And the machinery which we use has also evolved over a period of time. The cumbersome big machines which had to be brought to the patient's bedside graduated into more sleeker and much smaller machines, to the laptop like Sonocyte machines which we have been used to. And ultimately, the best paradigm I can see or I can claim is the availability of a single probe for all ultrasound, that is the butterfly ultrasound probe, which can do every ultrasound including obstetric ultrasound for your single probe, which is not a crystal based, but it's a chip based ultrasound connected to a tablet or an Android phone, which is brought into ultrasound or taking ultrasound to emergency rooms, operating rooms, and ICUs without the hassle of lugging around a heavy machine. That's probably the last paradigm I can see, and that will make ultrasound more easily applicable and widely practiced for the benefit of patients in the intensive care unit. So, friends, I think POCUS has been a true paradigm that has shifted and shifted for the benefit of patients in the intensive care unit. So think about it, and if you find that I've missed some more paradigm shifts in POCUS, please ping me, mail me, or call me on my number. Thank you very much and have a good day. Hello friends, welcome to my 8th iteration of paradigm shifts in intensive care. We have dealt with quite a few important paradigms. Some of them have made a difference to survival, some of them have made a difference to the morbidity and length of intensive care stay. Some of them have actually made the life of the intensivist easy, as POCUS has done. One area where I think paradigms have shifted for the better and have made significant difference to the outcomes of patients is in the field of neurocritical care. Nothing emphasizes the paradigm shifts and the improvement in the standard of care and the options available for patients in intensive care than the paradigm shifts that have happened in the area of acute ischemic stroke. When in 2000 and 2002, when I was just about beginning my career in intensive care, there was a kind of therapeutic nihilism towards approach to acute ischemic stroke, although thrombolysis was just about coming in the bigger and the well-informed units. But patients who had come beyond 3 hours were confined to the physiotherapy, nasogastric feeding, and a life confined to the bed with dependence on some others for activities of daily living. Now that paradigm has changed significantly thanks to imaging technology, thanks to the availability of better thrombolytic agents, thanks to the more easily accessible cath labs and professional expertise in doing intraarterial thrombolysis and thrombectomy and thrombus retrievals. These have actually increased the timelines for intervention in acute ischemic stroke. So much so today that somebody who presents even as late as 24 hours, if the imaging does suggest that there is a salvageable brain, there is evidence of reversibility, we are justified and in going ahead for a therapeutic intervention with reasonable neurological improvement. This single paradigm of providing multiple options for a patient with acute ischemic stroke has probably changed the lives of quite a few patients across the world and has been a true paradigm shift in the era of in the realm of critical care, and neurocritical care has led by example. So while we speak about this paradigm shift in the approach to stroke patients, something that has kept tandem with this is the accessibility and the relevance of neuroimaging. The number of tools that are available from an imaging perspective, especially from an MRI, in terms of an MR spectroscopy, MR flare sequencing, diffusion weighted imaging, and of course the availability of the CT angiogram, have probably contributed to a better structured and more informed decision making as far as assessment of a patient with acute ischemic stroke is concerned. It's probably not the timeline that makes a difference right now, but what has happened to the brain parenchyma, the tissue, that makes a difference as far as the diffusion weighted imaging results are concerned. So the improvement in outcomes among patients with this acute ischemic stroke, the increase in the options available has kept pace or kept hand in hand with the availability of the technology, the expertise, and the gadgetry needed for aggressive evaluation of these patients with acute ischemic stroke. The previous concept that MRIs would delay acute ischemic stroke treatment is probably no longer valid, because we go ahead with thrombolysis on the basis of a very short sequence of diffusion weighted imaging, and then we may be able to complete the intracranial and extracranial angiogram after the thrombolytic process is gone. So thrombolytic process is done. So management of acute ischemic stroke has now therefore become an integral team effort between the neuroradiologist, the neurointerventionist, and the intensivist, maybe the neurointensivist as well. So these two, improvement in the availability and interpretation of imaging, as well as the number of options available for patients with acute ischemic stroke, has been a very significant paradigm that has shifted in the last 20 years that I have been involved in this dynamic specialty of intensive care. So while this has happened, interpreting these images has become an integral part of the ICU training programs. Previously, when I was training, if you make out a subdural hematoma, an extradural hematoma, a hyperdense MCS sign, or an ischemic stroke, and a subarachnoid, your neuroradiology knowledge was considered adequate for an intensivist who has undergone formal training. But now, unless you can interpret the entire gamut of a brain MRI, your training is probably not complete, and you will probably have to you will probably have to rethink about your neuro training if you are not able to acquire enough skills in interpreting neuroradiology. So this has also been a paradigm shift, because intensivists are now learning or expected to learn the nuances of neuroradiology as well. Another area which has seen ups and downs, but technology has helped us to fine tune the treatment and rationalize certain over aggressive therapies and personalize probably the treatment options, is subarachnoid hemorrhage. There was a time between 2000 and 2005 when Triple H therapy was the norm. Triple H therapy was favored, and probably we did some harm to the patients by giving them too much fluid and tipping them over into fluid overload coupled with a neurogenic pulmonary edema. So the outcomes probably were not as good with the Triple H therapy. So while we understand that maintaining cerebral perfusion with the maintenance of blood pressure and euvolemic state are good, hypervolemia, as it is in the rest of the body, is probably not good for patients with subarachnoid hemorrhage. The availability of transcranial Doppler and the skill that is required to interpret it, coming from the radiologist, from the neuroradiologist to intensive care and to neurointensivist, has probably added to the clinical precision with which we can diagnose vasospasm, the quickness with which we can identify vasospasm and react to it. So this has also been a good paradigm shift for us. And because of the availability of higher imaging modalities, transcranial Doppler, and the availability of bedside EEG, about which we will speak a little later, we have been able to identify a new entity called as cortical spreading depolarization, which can explain the depressed sensorium in some of these patients with subarachnoid hemorrhage, which we were not able to do a few years ago. So acute ischemic stroke and subarachnoid hemorrhage probably have seen good paradigm shifts for the betterment of patient care in the field of neurointensive care. Meningitis also has seen some paradigm shifts, especially in terms of diagnosis. Previously, we had access only to gram stain and culture, and we were limited in what we could culture in the CSF samples. But now, with the ready availability of molecular diagnostics, a wide variety of pathogens which are known to produce meningitis and meningoencephalitis, even in immunocompetent patients, have been identified. Multiple case reports of organisms which we have only read in the textbooks have now come to the fore, and we have now in a better position to give precision medicine, precision antimicrobial therapy for patients with meningitis and meningoencephalitis, where the initial laboratory tests are equivocal or confusing, which will result in a cocktail of medications. So the availability of molecular diagnostics has probably contributed to a rational use of antimicrobial therapy, be it antiviral, antifungal, anti-helminthic, in addition to the antibiotic therapy, which is usually prescribed for patients with meningitis and meningoencephalitis. Steroids have had their say in the management of meningitis, but the paradigm shifts is going into a focused subset or cohort of patients who would benefit, but there is a rationalization in whom we use steroids in meningitis. Electroencephalogram has again been an important tool which has migrated from the outpatient departments to the bedside of the patients. And 24-hour EEGs have become standard of care for those patients with depressed sensorium who do not have an explainable cause for the altered sensorium, because we now understand that non-convulsive status epilepticus is a reasonably strong entity. It's not an uncommon entity. It can happen without a motor seizure ever for the patient, and it happens in patients with no known previous seizure disorder. So the availability of portable machines, the availability of 24-hour recording facilities has improved the ability of intensivists to diagnose non-convulsive status as well as the different patterns of epileptiform discharges. Now you have a very compact device which can project the EEG by Bluetooth to wherever you are. So that's been a paradigm shift. The EEG coming from the outpatient practice to the bedside, and from the bedside beaming those signals live to wherever you may be across the world, has been a paradigm shift which has contributed to early detection of certain major problems associated with seizure disorders in the intensive care unit. So just as imaging modalities like MRI and CT scan and transcranial Doppler have become essential skills which every intensivist has to learn, EEG has also become an integral part of the ICU curriculum, and it is now part of essential training for all intensivists who look after sick patients in the ICU. Another modality which has become more widely used in patients with neurocritical illnesses is therapeutic plasma exchange. It's been recommended for, of course, TTP for a long time, but certain conditions like a lupus cerebritis, for example, a hemolytic uremic syndrome, for example, hepatic encephalopathy where transplant is not an option, for example, or all conditions where therapeutic plasma exchange has come to the fore, and this technique again has become an integral part of our training process in intensive care training. Multimodal monitoring, which has become compact, which can be administered with a single device, is changed the way we are looking at CNS manifestations, entropy, and all the abnormal patterns that happen in a patient with neurocritical illness. So the availability of multimodal monitoring has probably been a good paradigm shift for patients who are in the neurointensive care. You need a paradigm shift which helps the intensivist to make a better and balanced decision making. Lot of debate has happened about hypertonic saline and mannitol. The paradigm is slowly shifting towards hypertonic saline, especially in traumatic brain injury and acute ischemic stroke. Although mannitol has its role in some cohorts of patients, the availability of hypertonic saline being an issue in this country, there is a little bit of paradigm shift towards using saline, even if it is 3% saline. And the paradigm shift has been that a lot of Indian authors are now working on 3% saline versus mannitol, so more data is expected. So we can expect more paradigms shifting in favor of 3% saline over the next few years. One of the other areas where paradigm shift has happened to the betterment of patients and in the interest of patient safety is the emergence of non-invasive methods of monitoring intracranial pressure. The gold standard still remains a ventricular drain because it has a therapeutic potential, but evidence seems to suggest that such an invasive method of measuring and targeting CPP is not associated with better neurological outcomes. But interventions may be done by non-invasive techniques like a combination of an optic nerve sheath diameter assessment and combining it with the transcranial Doppler pattern. So the availability of technology, the availability of the expertise, and the recognition of the physiological or the pathophysiological changes that accompany raised intracranial pressure have been paradigm shifts, and non-invasive methods have really made this aspect of neurointensive care safer for patients and more easily applicable to a wider cohort of intensive care patients. Now, the other area where neurointensivists and neurocritical care services have played a big role is to streamline the process of brain death certification and brain death awareness. The care of a brain dead donor has now become streamlined. The guidelines, which are published by several societies, have now more or less become uniform, and the paradigm has now shifted to a more robust and a more comprehensive support of the potential organ donor who can contribute to the improved life of up to 13 people in one go. So, neurointensive care has also not just saved the one patient with raised ICP or the one patient with a acute ischemic stroke, but by improving its awareness and spreading awareness about organ donation has improved the way organ donation program across the country has improved, and the numbers of people coming forward for organ donation has increased over the last 20 years. Neuro rehab is another area where paradigm shifts have happened, and the number of devices which are available, including robotic devices which are applicable, which are effective for patients who are quadriplegic and paraplegic, are available across the country. Trained practitioners of the field of rehabilitation medicine are now available in this country, and the acceptance among the treating intensivists and other specialists that you can't be doing everything like acute medicine, the follow-up care as well as rehab has dawned on them. So we are more ready at this point of time, more willing to accept that there are specialists in the field of rehab medicine, and we are willing to send our patients to rehab centers. So that's been a good paradigm shift. Lastly, I would not be doing justice by talking about paradigm shifts if I don't talk about the emergence of the gut-brain axis. It's a two-way axis. This paradigm has emerged in the last 3-4 years, where something that goes wrong in the brain is associated with a dysfunctional gut, and this is known from a long time. But the important aspect is the dysfunction of the brain has its origins in a dysfunctional gut, and this gut-brain axis plays an important role in the overall improvement or deterioration of a patient admitted to the ICU for a wide variety of reasons, not necessarily a neurological condition. So the emergence of this concept of the gut-brain axis has been essential, and it has been a very important paradigm shift that has happened in the field of neurocritical care. So, friends, these are some of my thoughts about the paradigm shifts that have happened in neurocritical care. If you please think about it, and if you feel I have missed something, please do write to me, ping me, or WhatsApp me. Happy to acknowledge it. Thank you very much. Have a good day, and Eid Mubarak to all of you in advance. Thank you. Hello, friends, and I hope you had a good Eid, and I hope you have all been able to attend the 8th edition of the Hyderabad Intensive Care Symposium. Today, in continuation with the reminiscences and my recollections of what paradigms have shifted in the last 20 years, where I have spent in this dynamic field of intensive care, I probably thought I'll speak about paradigms which have not so much shifted, where sound physiological rationale has not translated into clinical benefit, and we had to give up certain interesting concepts. One such interesting concept, which I have personally worked on, and then I've done a little bit of original publications on this, is about tight glycemic control. When I started my career in intensive care in 2000 2001, the first Vandenberg trial was published, which said that intensive glycemic control or tight glycemic control with a target GRDS of 80 to 110 is associated with better survival among critically ill patients. That seemed, something that is very logical, because hyperglycemia is known to produce a lot of complications in critically ill patients. But one of my mentors, one of my gurus, you may say, Dr. Vineet Nair at the Manipal hospitals, felt that this was too drastic to be applied for patients with deranged homeostasis. And we did a comparative study of looking at 80 to 110 versus 130 to 150 in those days, in 2002, 2003. And then we found that patients with the tight glycemic control tended to have more hypoglycemic episodes and probably stayed longer in the intensive care unit. This fact was subsequently corroborated by several other studies, including the NICE sugar, which said that 80 to 110 is a very tight target and cannot be safely practiced among critically ill patients, while we still have some scope and leverage to practice the tight glycemic control among surgical patients. The same thing applies to post cardiac surgery patients and other cohorts of patients. So, tight glycemic control, although a very good physiological concept, did not translate into clinical benefit, and more so, it was associated with adverse events among patients in whom this kind of strategy was followed. So, that's one paradigm which probably did not withstand the test of time. Another similar physiological rationale which had its limelight way back in 2000, 2002, 2004, but has slowly waned off is SCVO2. Ever since Emmanuel Rivers published his seminal paper about resuscitation among patients in the emergency room, so called early goal directed therapy, the SCVO2 became an integral part of markers of resuscitation, to the point that we were targeting an SCVO2 of 70 and above for adequacy of resuscitation. Subsequently, we understood the importance of venous hyperoxia, that is, SCVO2 of more than 80% being detrimental or being a marker of poor outcomes among patients with sepsis and septic shock who required hemodynamic optimization. But trying to optimize SCVO2 by blood transfusions or by infusion of dobutamine was not associated with better outcomes among critically ill patients. So, the SCVO2, although is a physiologically strong principle, is a strong rationale, could not then become an integral part of resuscitation algorithms, although it still can be perceived as a marker of tissue hypoxia and uncoupling of the electron transport chain at the periphery. So, when we spoke about blood transfusions, again, some paradigms which, high hemoglobin, for example, did not again withstand the test of rigorous scientific scrutiny. Ever since the first trick paper published from the Canadian Critical Care Group showed that conservative hemoglobin target of 7 grams per deciliter are safe, they are not associated with higher incidence of coronary ischemia among a general cohort of critically ill patients. Several studies have looked at different subpopulations of these patients and have found that a more modest or a more conservative target of 21% of hematocrit, that is 7 grams per deciliter of hemoglobin, is probably as good as a higher target. Maybe patients with acute ongoing myocardial ischemia with cardiogenic shock may be a cohort of patients who will not be candidates for this kind of conservative hemoglobin targets. Maybe the pregnant lady, maybe the bleeding trauma patient. These are all not patients who will qualify for this low hemoglobin target, but overall, the general cohort of critically ill patients seem to be better off, seem to be safer, and seem to be unharmed by a conservative oxygen target of 7 grams per deciliter, that is a hematocrit of 21%. So, this paradigm that more hemoglobin means more oxygen delivery, which was also a part of the reverse algorithm, also has waned off and is no longer considered as standard of care in intensive care. Another interesting device, which actually was used quite often and was believed as a lifesaver among patients with cardiogenic shock, is the intra-aortic balloon counterpulsation, IABP. In the early part of 2000 up to 2010 and 2012, IABP was an integral part of the therapeutic process or therapeutic algorithm for management of patients with cardiogenic shock. But ever since the shock trial, the IABP shock trial showed that general cardiogenic shock patients with decreasing requirement for vasopressor and inotropic support do not benefit from the use of IABP. The enthusiasm about using this particular tool for optimization of coronary blood flow has slowly waned off. There may be a small cohort of patients who are in severe cardiogenic shock with very poor ejection fraction who may still need the transient support with the balloon counterpulsation, but it cannot be considered that IABP is an integral and a must do for all patients with cardiogenic shock. With the advent of ECMO, the veno-arterial ECMO, and more recently the availability of the assist devices, both the right and the left ventricular assist devices, probably seems to have pushed the IABP back further in the pecking order in terms of instruments and tools you choose to optimize patients with cardiogenic shock. Another interesting paradigm which has fluctuated to and fro ever since 2000 2001 till recently has been the use of steroids in septic shock. The original Anand paper recommended that 50 milligrams 6th hourly of hydrocortisone combined with fludrocortisone is associated with better hemodynamic profile, earlier weaning up of vasopressors, and probably shorter ICU stays among patients with septic shock. But as we followed this algorithm and as the standard of care for sepsis improved across the world, as the Surviving Sepsis campaign guidelines came to be standardized and followed more rigorously across the world, the benefit with infusion of hydrocortisone and specifically fludrocortisone seems to have waned off. Several studies were then published which argued in favor and which didn't support or did not give so much of enthusiastic reply or confirmation that steroids in septic shock are beneficial. But of late, we have seen that again it's back to a combination of hydrocortisone and fludrocortisone in the most recent COST trial, which says that probably a combination of fludrocortisone and hydrocortisone in the dose described originally by Anand is probably good enough for vasopressor sparing and shock reversal among patients with sepsis and septic shock. So that's one paradigm which is swinging like a yo-yo in the management of patients with sepsis and septic shock. Of course, we all know that a sound physiological or a pharmacological principle like activated protein C did not sustain the test of scientific scrutiny after the initial industry supported trials confirmed that it's a good tool to use in patients with sepsis and septic shock. Now, another interesting aspect where the paradigms have not shown to be of benefit or have not shifted or have probably not changed much has been in the use of bicarbonate in the use of in patients with metabolic acidosis. It has always been considered as cover-up operation, as a cosmetic response to a basic, drastic, underlying life-threatening problem that is metabolic acidosis. But recently, the Bicar ICU trial raised a flag saying, yes, you may have some improvement among patients with shock who have metabolic acidosis with the administration of Bicar ICU, but with the administration of sodium bicarbonate. But the point to remember is what was the endpoint which was studied in the Bicar ICU trial. The Bicar ICU trial looked at better bicarb and better pH. Yes, administration of exogenous bicarb does give you good numbers, does give you a good pH, does give you a good ABG. At the end of the day, you are left with good numbers, and a dead patient is not what we are looking for as intensive care practitioners. So, if your endpoint is shock reversal, if your endpoint is vasopressor requirement, if your endpoint is RRT requirement, and if your endpoint is ICU length of stay, then probably bicarbonate has not actually been shown to be of much benefit. Another area where a good intervention which has not been able to show comparative results when used aggressively among sick patients has been in the role of decompressive craniectomy in trauma, right? Then this paradigm is a little interesting paradigm because decompressive craniectomy in ischemic stroke has been associated with better stroke outcomes and better coma outcome scores than when compared to trauma. So in trauma, the DECRA trial actually struggled to recruit enough patients. They overshot the recruitment period, but nevertheless, the finding has been a negative trial saying that decompressive craniectomy in trauma is not beneficial in patients with raised ICP. So, how does it actually all boil down to? It probably means that we haven't understood the pathophysiology of neuroregulation and cerebral hemodynamics as yet. The pathophysiology of traumatic brain injury is much different from the pathophysiology of an acute ischemic stroke, much as acute ischemic stroke differs from subarachnoid hemorrhage. So, these two cohorts of patients, that is trauma and acute ischemic stroke, probably differ a little, in their blood-brain barrier permeability and the autoregulation being preserved versus the autoregulation being deranged, and that's probably where decompressive craniectomy has not been shown to be of much benefit. Albumin is again something that has come in and gone out. People prefer to use it initially, but later on, the role of albumin has become confined to the hepatic and liver failure units. Whether you look at trauma patients, whether you look at septic shock patients, whether you look at any cohort of patients other than those with hepatorenal syndrome, large volume paracentesis, and acute liver failure, we were not able to show much benefit with the use of albumin. So although it looks like it's a like for like replacement, you lose fluid, you replace it, you lose hemoglobin, you replace it, so you are low in albumin, you replace it. That somehow does not seem to be as simple as 1 plus 1 is equal to 2. So the waning off of albumin has been another paradigm which failed to impress and failed to register itself as a paradigm that could be transferred. Here I must say my disappointment with high frequency oscillatory ventilation in ARDS. During my initial stages as a practicing consultant, I was much impressed and enamored by high frequency oscillatory ventilation, and I was trying to convince the people where I worked to buy an HFO machine for adult patients with ARDS. But as I was able to succeed, as I was able to convince them and they were about to sanction the machine, came the two dampeners, the Oscillate and the OSCAR trials, which one of them did not show benefit and the other one actually showed harm with the use of high frequency oscillatory ventilation among patients with ARDS. So again, an interesting physiologically sound principle did not stand the test of scrutiny in a rigorous randomized controlled trial. So the interest in while it still continues to be used in some pediatric cohorts of patients, its role, its presence in adult intensive care units has graddually dwindled down. Glutamine, made a big name for itself in the initial part of the 2000 2004. People said in burns it helps, in traumatic brain injury it helps. Some said it will regenerate your enterocytes, so your gut-brain axis gets preserved. And oral glutamine versus parenteral glutamine. At the end of the day, glutamine as an immunonutrient failed to show much improvement in the hemodynamic and vasopressor profile of critically ill patients. So that's another uh, hypothetically good concept that did not stand the test of scrutiny. But in my view, the biggest physiologically sound tool which gives you a bucket load of information which has not been validated, not been vindicated by a large positive randomized control trial is the pulmonary artery catheter. People still say it is the gold standard for hemodynamic monitoring. People will still compare all the new hemodynamic tools against the results of the pulmonary artery catheter. But ever since the Connor paper came, which came long ago, said that it doesn't make a difference to the outcome of critically ill patients, the pulmonary artery catheter has slowly found its way out of the intensive care unit, the general intensive care units. Although the specialized cardiac care units may still use the PA catheter, the information you get from it is very tangible, very sensible, and actionable. But as a tool, its role has actually not caught on, and it's maybe the younger guys who are training in intensive care have not even learned how to float a swan. Yes, you can still get information from an echo, you can get some information from the PICO monitors, but the hemodynamic and the waveform information which we used to get from pulmonary artery catheter, and the interpretation as it progresses from the internal jugular vein right up to the west zones, was something which could make you revise your physiology and make a decision. But I think the decisions which were made based on the pulmonary artery catheter did not influence the outcomes among patients. So the tool became something that was considered as ineffective or not a good tool to be used in the intensive care unit. So these are some of the units aspects, friends, where good sound physiological principles did not stand the test of rigorous scientific scrutiny. So while physiology seems to argue in their favor, the clinical scientific research has not shown them to be effective, and that's the beauty of intensive care. A patient in the intensive care unit is a completely different physiology, is a complete different ball game, and that's where we as intensivists have to make personalized decisions, and that's what I think I have realized over the last 20 years. Thank you very much, and we'll meet again sometime later. Thank you. Hi friends, I'm back again with the 10th edition of my iterations and reminiscences of the paradigms that have shifted or changed in my last 20 years as an intensivist. I'm surprised that I've actually reached the 10th episode I was able to recollect about 8 such episodes where the paradigms have actually shifted. And in the 9th episode, actually, I spoke about paradigms which are yet to shift, or where robust physiological rationale has not met the success of a rigorous randomized controlled trial. So it means that this dynamic specialty is truly dynamic, and it keeps changing and keeps teaching you new lessons every now and then. Some of you might actually be surprised at my attire today, formal attire. If you think it's a paradigm shift, I'm quite happy about it, but I just walked in after a board meeting, so I thought I'll finish this recording as well. Anyway, so while I spoke about the practices and the principles of intensive care which have changed over the last 20 years, I actually have thought about the specialty of critical care itself, the way it has changed over the last 20 years. And today I want to talk to you about a little bit about this. Now, this specialty is a dynamic, wonderful, and very gratifying specialty. I'm sure most of you would accept that. But when I started my career way back in 2000 as an intensivist, now at that time, the IDCCM course was the only beacon of light, was the only ray of hope for all of us who were aspiring to be intensivists. And Maybe in 2001, the national board started the 2-year fellowship in critical care. In the first year, it was chosen left to the institutes to recruit candidates, and the second year, in 2002, the formalized entry exam was conducted for all India selection of these candidates, and I was the first batch who happened to come under the tutelage of the legendary Vineet Nair, followed by Jose Chaco at the Manipal Hospital, and I'm grateful that I came under the guidance of these two stalwarts at such a young age in my life. From then on, this specialty has grown by leaps and bounds. So the point that it was recognized as a standalone super specialty in 2017 by the the Medical Council of India, which is now known as the NMC, and there was a retrospective recognition given to those who had completed their FNB. Now, this actually boosted the morale of a lot of us who completed our training and went abroad for fine tuning our skills in Australia and the United Kingdom, and encouraged us to come back and take up teaching posts either in teaching hospitals and universities or in corporate hospitals which were keen to run training programs. And that's what I did by starting the National Board Fellowship at Care Hospitals, Hyderabad, and ran it for a good 9 years. So that gave us a good paradigm shift of trying to find your future overseas, then to come back and give back to this country what the country has given to you as an undergraduate and postgraduate and a super specialty training. So as more and more such specialists became available in this country, hospitals which were starting new units, setting up new intensive care units, understood and realized that formally qualified specialists in the field of intensive care are required to be on the regular staff of a critical care unit, and that actually was a huge paradigm shift. And more of my colleagues, my contemporaries who qualified and came back were able to find jobs in good institutes and do excellent work over the last 20 years. And so as it progressed, the accreditation boards also understood that the presence of a critical care qualified specialist is an essential aspect of having a good intensive care as far as accreditation standards is concerned. So the emergence of the specialty, this recognition by the Medical Council, the acceptance that such specialists are required first by the hospital managements and next by the accreditation boards has been a huge favorable paradigm shift for us as intensivists. As the specialty grew and we acquired more knowledge about the specialty, its nuances, its intricacies, and its variations in different organ systems, certain subspecialties did emerge. The prime ones among them being neurocritical care, cardiac intensive care, and transplant intensive care. But the most recent one is the obstetric critical care. Neurointensive care has its own fellowship in this country, which is run by a robust system and exit exam. Cardiac anesthesia and intensive care has again a highly specialized program with its own nuances. Now with the advent and accessibility of ventricular assist devices, now these skilled specialists will be in great demand across the country. Transplants, the COVID pandemic triggered a whole series of patients who are in need for a lung transplant. And most big hospitals in the country have set up or are in the process of setting up lung transplant centers. And they are not shying away from trying to send their senior professionals overseas to the best of transplant centers with outstanding results to get themselves trained in the intricacies of the immediate perioperative and postoperative care of lung transplant recipients. And intensivists have been in the forefront of these training programs as well. So as the obstetric critical care is again something which is caught on, and a lot of training programs have come in, not least to say that the ISCCM has itself embarked on an online training module on obstetric critical care, which will be launched very soon. So as these specialties have increased and as our ability to look after multiple subspecialties has increased, the need to acquire more technical skills has also increased on the part of a trainee who enters into intensive care. We were only required to learn the basics of chest radiography and CT scan, maybe acquire the skills of interpreting a basic left ventricular echo, and maybe towards the end of our training we learned about vascular ultrasound and a little bit about ECMO. But now Every trainee is expected to know a lot about point of care ultrasound, right from the TCD, right from optic nerve sheath diameter, lung ultrasound, diaphragmatic ultrasound, right ventricular assessment by sonography, EFAST, assessment of the renal Doppler index as part of the VEXAS protocol, and bladder sonography for anuric or oliguric patients. These are all become integral skills for an intensive care trainee to learn. Similarly, not only sonography, intensive care trainees are now expected to learn a lot about radiology as well. You need to know how to interpret a contrast enhanced CT of the chest to exclude dissections and pulmonary emboli. You need to look at a contrast enhanced CT of the abdomen, mainly for patient pancreatitis and pseudomembranous colitis and intra-abdominal catastrophes. You are expected to know how to interpret the entire stroke series of flare, diffusion weighted, T1, T2 weighted, and spectroscopy images of the. And some of us are probably required to understand, if you're working in a high-end oncology center, to probably interpret the basics of PET CT as well. So essential radiology skills which we were expected to know 20 years ago have increased, and the expectations of a candidate as far as radiology skills has also increased. One of the other areas where the skill sets of intensive care trainees is expected more is in the area of renal replacement therapy and multi-organ support systems. So you have different types of cartridges, not only for renal support, but for poisoning, for lupus, for hyperbilirubinemia. You have the ECMO circuits running with CRRT. You have the therapeutic plasma exchange running with CRRT. So a trainee in critical care is not only expected to know the dose of dialysis, the modalities of renal replacement therapy, but also the other circuits which are possible to be connected to a critically ill patient with a complex multi-system problem. So multi-organ support system has now become an essential, at least a knowledge base, which every intensive care trainee is expected to have. While all this has happened, the intensive care trainee is also expected to know a totally different kinds of pharmacological approach to the drugs which he is using in the intensive care unit. So a trainee in intensive care is expected to know the lipophilic and hydrophilic antibiotics, their cycle of distribution, their volume of distribution, whether it's a time dependent or a concentration dependent antibiotic, and how this antibiotic behaves when given in a patient with intermittent hemodialysis, or how it behaves in a patient on SLEDF, or how it behaves in a patient on CRRT, and what if ECMO is added to the CRRT circuit. So the pharmacological competence of an intensive care trainee is expected to be at a much higher level than super specialty trainees of other specialties like cardiology, nephrology, gastro, and neuro. So our knowledge base requirement is probably wider than other trainees. While we acquired more of these skills and knowledge and kept ourselves abreast and become highly skilled operators, we have also become part of teams which are providing intensive care outside the four walls of this ICU. And I myself am aware of several big teams in this country which offer services outside the ICU in the home ICU setup. As the burden of bed occupancy in hospitals increases, more and more patients are now going home on supports. Even when we were not as skilled or as educated as we are now, we have looked after a patient with motor neuron disease on ventilatory support for close to 2.5 years until she succumbed to a pulmonary thromboembolus. So home care and intensivist involvement in such home care has become very widespread, and that's been a paradigm shift I have noticed in the last 20 years. Not only in home care, the intensive care specialists have become part of the MET teams in most streamlined hospitals. So we have become guides, we have become advisors, and we have become the team leaders of the MET teams to pick up early warning signs and identify those patients who need to be brought into the intensive care and resuscitated quickly and early and appropriately to decrease the burden of critical care on the intensive care and the patient's family. So this kind of knowledge, the availability of highly skilled trainees, the recognition of this specialty has spawned the emergence of well-equipped ICUs in Tier 2 and Tier 3 cities. This has got to be linked with the emergence of tele-ICU. I have been enamored by tele-ICU ever since I set foot in this country way back in 2006. But there are, I know, very big teams in this country which provide high quality tele-ICU service, going to the depth of the country, reaching to the hinterland of the country, and giving advice to people dealing with snake bites, poisonings, an obstetric patient who is seizing, a drowning victim, and trying to give method to what they are doing, guide them by a hand-holding approach, and then limit the morbidity which delayed treatment can happen, and prevent such sick patient having to withstand a travel of 300 or 200 kilometers to a tier 1 city. So the availability of tele ICUs, the availability of skilled manpower who can man these tele ICUs, and the availability of highly skilled professionals and well equipped ICUs in tier 2 and tier 3 cities has been a big paradigm shift, and I'm sure this will change the face of healthcare, especially intensive care in this country in the days to come. So while we have done this, while we have trained ourselves in so many skills, we have extended it outside the ICU, we have learnt how to guide people sitting in a remote place. Our access to knowledge has also increased, and that's been a big paradigm shift for me. Way back in 2002, when I was a trainee, the only access to us was taking help from some of our friends overseas to give us original articles from the NEJM, Lancet, and CCM. If we were lucky enough to work with good bosses like I did, they were magnanimous enough to give their personal online search portal login IDs to us, and we were able to use them and download information. Otherwise, the only option you had is to walk across to a university library, through sieve through a whole bunch of journals and find out what appeals to you. But now, access to information has jumped by leaps and bounds. There are several big active WhatsApp groups operating in this country which give a lot of information whenever somebody wants it. They are able to guide people with good advice backed by evidence and articles even at 2 a.m. or 3 a.m. in the morning, and help people troubleshoot when they need it. Of course, there is the problem of individual personalized experiences being posted on such groups, but it's always good to know a pro and a con view when you are dealing with a problem, and you take a balanced decision on what to do for the patient. And of course, there are always others who will give you a balanced view and give you the latest reference guidelines and articles on the topic which you are seeking to understand. So that's been a good paradigm shift as far as I'm concerned. The conferences have increased, the quality of the conferences has increased, and web-based conferences have become the norm. We ourselves have conducted a 3-day online Hyderabad Intensive Care Symposium for the second time this year, and we were able to get a far wider audience than we would have got had we done a physical conference. Probably hybrid conferences are the way to go for future, and that I'm seeing that as a paradigm shift in the way medical information is shared and disseminated to those desirous of acquiring such information. So with all this information, a trainee who appears for an exam is expected to come better informed and with a lot of expectations from the examiners than what we were when we were appearing for exams, whether in India or overseas. So today, an examinee or a candidate who appears for an exam is expected to know a lot about renal replacement therapy, point of care ultrasound, extracorporeal techniques, drug dosing, and whatever I spoke about as paradigm shifts in learning, they are expected to know. So the standards of exams have increased, which means the output of such exams has increased. That means the quality of candidates who are coming out of these exams is much, much better and superior probably to what we were when we passed out of our exams way back in 2002, 2003. So overall, the quality of professionals who are now manning intensive care units has increased and improved, and that's been an excellent paradigm shift for me as well. But what has been the most gratifying paradigm shift for me is that Indian researchers have made an impact in the world of critical care decision making. I will just quote three examples which come offhand to my mind. Is that one of our past presidents, being a member of the group that wrote down the Surviving Sepsis campaign latest guidelines. And it cannot be, more than an honor for all of us that he was our representative. He was our past president. Similarly, one of our past presidents has been the pioneer for recommending the tidal volume challenge test for assessment of fluid responsiveness, and that has changed the paradigm of dynamic indices of hemodynamic monitoring. Another past president of ours has been an author of a low cost intervention of high impact value, the use of doxycycline and macrolide for the treatment of scrub typhus, which is a particularly relevant problem in the Indian context, and to be published in a highly rated and highly accomplished journal is a moment of pride, not only for him and his team, but for all of us as members of the Indian Society of Critical Care Medicine. So, I'm sure there are many such pioneers I might have missed, and I apologize to them for that. But the work of all such path breakers has made the world community sit up and take notice of Indian researchers. And when an Indian research project or a paper is presented, whether in the World Federation or at Brussels, researchers all over the world are sitting up and noticing, let us listen to what these guys are doing. And it was obvious in the last Eurasia that the Europeans are actually giving us more importance and have acknowledged our contribution. It's probably going to be the same in the upcoming Eurasia as well. So friends, अच्छे दिन आने वाले हैं. It's not a political slogan. I'm saying this for the society. I think we are growing, the paradigms are shifting, the specialty is growing. Yes, there have been instances of assaults on us, there have been instances of the administration demeaning and belittling us, but that's because we are holding the banner and standing in the front. So a front runner, an opening batsman will face a bouncer. It's not easy for an opener, and an opening batsman cannot expect to face a flat track, straight, non-spinning ball. So that's all, friends. I'll meet you again next week with some more quiet contemplations. Have a good day. Bye bye.